Hi, and welcome to my presentation on blood pressure regulation. This is actually quite a summarized version of what I used to have, which was maybe 30 or 40 slides. And I think you'll find, even though it looks a little bit complicated, this is probably an easier way to try to grasp it than to have it broken up into many, many slides. So what we're going to start off with is a scenario that would be actually a decrease in blood pressure. And you could kind of assume that if you had the opposite, which is a rapid increase or increase in blood pressure, that most of these things would go the opposite way. And for the most part, it's just reversing the arrows and that kind of thing. So I'm not going to go over both scenarios. I'll just go over this one and then again assume the opposite. So you can have lower arterial blood pressure happening rapidly. If you stand up, it'll happen in the carotid arteries quite rapidly. If you lose a lot of blood rapidly, if you have septic shock or anaphylactic shock from an allergy, or you could just have fluid loss, which could be a little bit slower, or dehydration, which could take a little bit longer. But in general, the body does pretty much the same thing to try to regulate that blood pressure and get it back to normal. So the way I have this broken up is at the top in yellow is roughly the sensory pathway. So some of it might be in a gray area, but what I mean by that is it's the part that of your body is saying, well, okay, what is the blood pressure right now? It's the sensation of that. How do you detect the blood pressure? The next part, though, in blue, is how do we respond to that to fix it? Okay, so again, there's some gray areas where it's kind of like, for example, the beta 1 receptors might be a little bit. Might argue that that's the output rather than the input, but that doesn't really matter at this point. So let's go ahead and jump into it. So each one of these, or most of these, have a little image on them that indicate what I'm talking about. So, right, so that would be, for example, basically the carotid. It could be, well, the aortic arch or carotid artery coming off. Okay, so this whole thing is we're talking that area of the body. Okay, in the blood vessels there. So we have a decrease in stretch in the carotid arteries or the aortic sinuses. Actually, carotid sinuses or aortic sinuses, and that means the specific regions in those blood vessels that are actually sensing the pressure or the stretch, and those are actually called baroreceptors. Okay, the baroreceptors are pressure receptors. They are right embedded in those blood vessels, but they signal to the medulla in the brainstem, and then the brainstem has to have some kind of reaction to that to try to correct whatever the issue is, in this case, low blood pressure. So the first thing that would happen, and don't worry, we're going to jump to the other side later, but I'm going to stay on this side for now. So what will happen is we'll decrease the parasympathetic nervous system activity going to the heart. That'll cause an increase in heart rate. Will increase the sympathetic nervous system activity, and that would be epinephrine and norepinephrine. Remember, norepinephrine is a neurohormone because most of it is from the neurons functioning as a neurotransmitter. Some of it is from the adrenal medulla functioning as a hormone. Epinephrine, okay, is from only from the adrenal medulla, so it's strictly a hormone. Okay, and that is again, the reminder here is the kidney with the adrenal gland on top of that. So epinephrine can bind to well, let's continue where we were at the heart. Epinephrine can bind right to the heart and increase the heart rate. Norepinephrine can also bind to the heart, which is down here, and increase the heart rate. Okay, so what I did was any of these arrows glowing in blue are meant to indicate that there's more than one substance doing that. So in this case, both norepinephrine and epinephrine are triggering that. Okay, triggering the heart rate. So on the other hand, one of the things that you'll find in these pathways is, sometimes there will be things kind of counteracting it a little bit. In this case, epinephrine is actually binding to beta 2 receptors on blood vessels, causing vasodilation. It's also binding to alpha-1 receptors, causing vasoconstriction. So, so you might be asking, well, why is it doing opposite things? And that's because some blood vessels will have more beta-2 activity. Some blood vessels will have more alpha-1 or activity or alpha-1 receptors, and it depends on the relevance of that blood vessel. So if it's in skeletal muscle, there should be more beta-2 receptors because you need to dilate your blood vessels in skeletal muscle when you're exercising or when you have adrenaline, which is epinephrine, same thing. So we will still dilate during exercise in some areas, whereas in other areas alpha-1 dominates, such as in the gastrointestinal arteries and things like that. Okay, I'm not going to get too much into all those organs here, but I just wanted you to understand that epinephrine is not a pure vasoconstrictor, whereas norepinephrine is only really activating alpha-1, so that I call that a pure vasoconstrictor. Even though these two look the same structurally, they almost look the same. Their names are very similar. They're not identical, though, in terms of what they do. Okay, so when we cause vasoconstriction, okay, that term means constricting blood vessels. It could be arteries, it could be veins. Most people usually mean arteries or arterioles, but I'm going to separate the two here because they do two different things or two different outcomes. So venoconstriction or constricting veins decreases venous capacitance, and that might sound like a strange term or not familiar, but even though if you look it up, it's a little bit of a complicated definition. I just want you to, I want it to be simplified, and I want you to understand that it just means that your veins, when they're getting constricted or smaller, there's less capacity for blood, but the blood has to go somewhere when they get constricted, so it ends up going back to the heart through the superior and inferior vena cava, so it increases venous return. Okay, so here we have venous return, and then we have an increase in diastolic stretch. That means while the heart is filling, it's going to stretch more and more and more, and the more blood returning, the more stretch. And then we're going to increase cardiac inotropy, or the force of the heart contraction, which increases the stroke volume, which is the volume of blood pumping per each beat or each systole cycle. So you might think, well, it makes sense, right? If you stretch the heart more, it will retract or have more elastic recoil, so it'll be pushing stronger to push the blood forward. But it's not that simple. The heart actually, when you stretch it, it actually places the actin and myosin filaments in a more efficient lining up. They line up basically more effectively, without getting into too much detail, to give you a stronger force of contraction. So it's not just a simple elasticity effect there. So more stroke volume means more cardiac output. More heart rate means more cardiac output. And cardiac output is one of the main factors affecting arterial blood pressure. More cardiac output means more blood pressure. The other side of this is directly in the arteries, and that would be called peripheral resistance or afterload. And that means what is the resistance that the arteries are creating that's going to limit the amount of blood that can get out of the heart and go into the arterial system. And what I mean by that is, if the arteries are smaller or constricted, the heart has to pump stronger to move blood forward. So that is called afterload because it's after the heart with respect to the order of blood flow. So constricting arterioles through, again, norepinephrine or epinephrine will cause increased afterload, and that will also increase arterial blood pressure. That's one side of the story, a very important side of the story. The other side of the story is related to the kidneys. So all these up here, these 5 different kind of boxes in yellow, are all related to the kidney or what's going on in the kidney. Okay, and even as we go further down, it's a lot of kidney stuff. So the kidneys have stretch receptors or baroreceptors just like the aorta and the carotid arteries. Okay, so when the kidney baroreceptors sense low blood pressure, because if the whole body is low blood pressure, generally the kidneys will typically have low blood pressure. And what happens is these tiny little vessels called afferent arterioles that are going into each tubule, particularly each glomerulus, which is a bundle of capillaries, and it's about 1 million, again, about 1 million of those bundles or glomeruli in each kidney, and about 1 million of these afferent arterioles. So they're very small. But what happens is the arteriole senses low pressure, and it's got an integrated system, meaning it actually releases a chemical directly from its own cells, right? The arteriolar cells can release a chemical called renin, and renin ultimately will increase blood pressure through kind of a long process that we're going to talk about in a little bit, okay? Which some of you or all of you should have learned about at some point. Okay, so the other things that can happen here, there's 3 major triggers for renin release. So it's the intrarenal baroreceptors. It's also beta-1 receptors, which happen to be the same receptors that are on the heart, right? Also activated by norepinephrine and epinephrine. So this is where you're bridging the sympathetic nervous system with renin in the renal part of the pathway. So these are connected. So I like to think of it kind of this way, that the 2 on the right are the kidney's own inherent mechanism, whereas the beta-1 receptors are the body's way of telling the kidney we need more pressure throughout the whole body. So the sympathetic nervous system is innervating everything or many things. Part of that is the kidneys, and it's saying basically give us more blood pressure because there's not enough in the carotid arteries, or there's not enough in the aorta, for example. So the final thing that would trigger renin release would be a really interesting, I think it's an interesting component of the kidneys, and that's at the not the very end, but somewhere middle to end of the tubules, or the nephrons, is called the ascending limb of the loop of Henle. So in that part of the tubule where urine is forming, there's a sensor for sodium, and if it senses that there's low sodium, either really the concentration or the delivery of sodium, the rate of delivery of sodium. So if there's low urine flow or low, basically low movement of sodium into those macula densa cells, it's going to signal right to the juxtaglomerular cells, which are again in the afferent arterioles. Those juxtaglomerular cells will also release renin in that case as well. And even though the macula densa is pretty far along the nephron wraps back around to the beginning where the glomerulus is. And so it is in very, very close proximity to the macula densa is very close proximity to the afferent arteriole. All that together causing renin release eventually causes an increase in angiotensin II, and I don't have the whole pathway here, but remember, renin converts angiotensinogen into angiotensin 1, which are both peptides. Angiotensin 1 is converted into angiotensin 2, and so renin does the first part, angiotensinogen into angiotensin 1. Angiotensin converting enzyme, or ACE, does the second part, which is converting angiotensin 1 into angiotensin 2. What I like to talk about here is that where are these enzymes that are doing this? A lot of times we talk about what's happening. Angiotensin converting enzyme, it does this, it does that, but we don't necessarily talk about where it's coming from. And I think that's relevant in the long term in your careers. I think it's important to understand the organs or tissues that are producing these things in case there's damage to that organ or tissue. It makes it easier to understand why things happen the way they do, and why the consequences are the way they are. So, understanding renin is from the kidney, but angiotensin converting enzyme is actually embedded in the blood vessel wall in the lungs, so all the blood vessels in the lungs, and then also in the kidney blood vessels. So I have a red blood cell there, but it just means really blood vessels. So angiotensin converting enzyme is not, a lot of people are tempted to saying, oh, it's in the kidney. Well, it's not just in the kidney. It's in blood vessels in different regions of the body, but primarily the lungs and kidney. Angiotensin 2, though, is the workhorse or the final messenger that's doing so many different things acutely and chronically. So what they call that is the rapid pressor response and the slow pressor response. So the rapid one is that angiotensin 2 causes an increase in norepinephrine release from the sympathetic neurons to immediately cause an increase in vasoconstriction and heart rate. Angiotensin 2 directly causes vasoconstriction through its own receptors, probably a little bit more arterial than venous, but it does both of those. Angiotensin 2 directly causes sodium reabsorption in the kidney, but then it does so indirectly by triggering the hormone aldosterone to come from the adrenal cortex. And a lot of students forget this, but aldosterone is a steroid, and if you look at the name, you can see that STER. That should indicate to you that that's a steroid. And because it's a steroid, it's coming from the adrenal cortex, which is on top of the kidney. It's not in the kidney, right? So it's a separate organ. So please keep that in mind. But aldosterone also causes sodium reabsorption. In case anyone forgot, reabsorption means moving sodium from the urine that's forming. So before it gets into the bladder, right? It's in the kidney. From that forming urine, it moves the sodium into the blood. Okay, so that's reabsorption. So aldosterone does it by upregulating sodium channels. Angiotensin 2 does it directly by upregulating sodium channels. And then finally, angiotensin 2 triggers antidiuretic hormone release from the pituitary gland, which is a totally separate location, right? It's in the brain. So that is a very, very interesting and unique effect. So angiotensin 2 almost has like this, how could I call it, like a pan effect, meaning affecting everything almost. So it does cause release of this ADH, and remember the name is antidiuretic hormone, so that means anti-urination or anti-fluid loss. So it's named in a very helpful manner. It's also called vasopressin, and some of you may have seen that in a hospital or in a pharmacy, or called arginine vasopressin, that can be used in patients that have hypovolemia and low blood pressure. So the reason why it's called vasopressin is because it does cause constriction of blood vessels. But it's called antidiuretic hormone also because it causes a direct upregulation of water channels called aquaporins in the end of the kidney tubules. So that would be in the collecting tubule of each nephron. In fact, the Nobel Prize was given because of the discovery of the aquaporins. A common misconception is that antidiuretic hormone causes sodium reabsorption. It doesn't cause sodium reabsorption, so it doesn't directly affect sodium. It directly causes water reabsorption. And then the other thing I wanted to add is, this is kind of a little bit separate, but when your brain, CSF in your blood vessels, their sense basically high osmolarity, meaning a lot of things are dissolved, but there's not a lot of fluid, so it's very concentrated substances dissolved in the CSF. Your brain will trigger thirst automatically. Okay, your brain will trigger thirst in order to recover more or get more water in the system. So you can get more water through drinking, or you can get more water by preventing it from being urinated. So I like to think of it as drinking from the mouth and then drinking from the kidney, because what you're actually doing is not allowing the urine to go all the way out. You're recovering it and putting it back into the blood. So you're getting water from both sides. Ultimately, again, we have a glowing arrow, so that means it's, both of these effects are going to raise fluid. So drinking and renal water reabsorption will keep your fluid up. That'll cause an increase in venous return. More venous return means more diastolic stretch. So back to the same thing again. Higher stroke volume, higher cardiac output, more atrial reflex means it's going to trigger the heart rate to go up. So what this means is that most of these things are really intimately connected with each other. So the sympathetic nervous system affects the renin part. That's called the RAS system, renin, angiotensin, aldosterone system. Angiotensin 2 affects the sympathetic nervous system, right, by increasing its activity. And then, right, the slow response is sodium and water reabsorption. So you get a rapid increase in blood pressure. And if you have a chronic low blood pressure, your body will try to cause more sodium and fluid retention. And if you happen to be a person that has any abnormality in these pathways, or you have trouble producing, for example, aldosterone, you might have to have a higher sodium diet, right? A high salt diet. There are exceptions where your body can't necessarily control these things. Usually, we're talking about high blood pressure in most countries. That's what we're worried about. But some people have a genetic predisposition to low blood pressure, right? And they have to use things to increase some of these activities, like drugs that work like aldosterone, drugs that work like antidiuretic hormone, or cause its release or something like that. So that pretty much wraps it up. Every one of these glowing boxes, by the way, do have extra information. Okay, so I click on that. You have more information. Click on this. So I encourage you to look, because I think I mentioned all of it, but if you look deeper, you'll get even more, and you'll be able to basically study that. But I guess the only thing I didn't mention is these things: the atrionatriuretic peptide and brain natriuretic peptide. Those are special peptides released directly from the heart when it's got too much fluid in it. Those actually try to work against all these other things because they cause sodium excretion from the kidney, so through the urine, and they cause vasodilation. These don't completely counteract everything, otherwise you'd never be able to regulate your blood pressure if it got low. But the reason why I like to mention ANP and BNP is because these are there are drugs that actually work just like these, or drugs that prevent their breakdown. So medications to intentionally used to increase sodium loss and to cause vasodilation. So, in fact, most components of this entire diagram are affected by medications. So I'd like to thank everyone for listening. Hopefully, this was very concise and kind of a good way to put it all together in one diagram and to understand it as a connected system rather than separate components. Hope everyone has a great day again, and thank you.